Good morning everyone. I am Dr. Rajni Kr Rai, Assistant Professor, Santosh Medical College, Department of Pharmacology. Today I will be teaching you about beta adrenergic blockers. So what are beta blockers? We will be discussing about what are beta blockers, where the beta receptors are located, their mechanism of action, how they act, their classification, their therapeutic uses, their drug interactions, adverse effects, and their contraindications. So now when we talk about beta blockers, what are they? They are the drugs which inhibit adrenergic response mediated by beta receptors. Now these beta receptors, where are they located and how many types are they? There are three types of beta receptors: beta 1, beta 2, beta 3. So beta 1 is located at heart, at Golgi cells in the kidney, at posterior pituitary and adipose tissue. Beta 1 on the receptors located on the heart causes stimulatory actions. Beta 1 receptors located on the Golgi cells causes renin release, and on pituitary, posterior pituitary causes ADH release, antidiuretic hormone release, and then on the adipose tissue, beta 1 receptors causes lipolysis. Now let's discuss about beta 2, its location and its action. Beta 2 receptors are located on bronchi, which leads to bronchodilation. They are located on the blood vessels of skeletal muscle, which causes vasodilatation. They are located on smooth muscles such as uterus, intestine, detrusor muscle of urinary bladder. They causes relaxation. On liver and muscle, it causes glycogenolysis. On an adipose tissue, here also it causes lipolysis. And on eye, beta 2 receptor causes enhanced aqueous secretion. Then beta 3 receptors are only located at adipose tissue and it causes lipolysis. Now let's discuss who classified these receptors. Professor Raymond T. Alquist in 1948 classified these adrenoreceptors. Now the first beta blocker, dichloroisoproterenol, in 1958 it was identified by James Black. Then pronethol came in 1962, then in 1963 the propranolol came, which is now also used, and then the newer beta blockers were identified. So how these beta blockers act? Their mechanism, actually the beta adrenergic blockers, they go and bind to the receptor, they block via GPCR, they block, and there is no stimulation of G protein and there is no change in cyclic AMP concentration in the environment there, and thus there is no effect. So they block the beta receptor action everywhere. So what happens? What are the properties of receptor blocker? There are non-selective beta blockade, selective beta 1 blockade, beta and alpha blockade. Then there is intrinsic sympathomimetic property. Then there is membrane stabilizing action, where it acts as local anesthetic and causes sodium channel block. Now let's classify beta blockers. The classification of beta blockers is into three generations. The first generation is classical, non-selective. The second generation is classical and beta 1 selective, and third generation is the newer generations of beta blockers. They are non-selective and they are beta 1 selective and has some additional property. Now let's discuss in detail about what are the first generation non-selective beta blockers. Non-selective beta blockers are, for example, with intrinsic sympathomimetic actions. Only there is one beta blocker, penbutalol, with membrane stabilizing action, propranolol, and with both in intrinsic sympathomimetic action and membrane stabilizing action, there is pindolol. Then without intrinsic sympathomimetic action, action and membrane stabilizing action are timolol and nadolol and sotalol. So they are the first generation non-selective ones. The second generation beta 1 selective agents are metoprolol and acebutolol, then atenolol and bisoprolol and esmolol. They are also known as cardioselective beta blockers because they are beta 1 selective. If you remember, the beta 1 receptors were located mostly at heart, so they are also known as cardioselective. The third generation is non-selective, divided into non-selective and selective. Non-selective one is the carbidiol, cartilalol, labetalol. Then selective ones are beta-soxolol and celiprolol. They are the third generation ones. The beta blockers are actually having properties of beta 1 selectivity, so they causes less bronchoconstriction, less interference with carbohydrate metabolism, so it causes less of hypoglycemia, so they are preferred in diabetes. So beta 1 selectivity is preferred in diabetic patients. There are less chances of Raynaud's phenomenon. They have less deleterious effect on blood lipid profile and less effects of tremor as well. Now, properties of intrinsic sympathomimetic action, when I was saying there, it means there is less bradycardia, there is less rebound effect on withdrawal of the beta blockers, less deleterious effect on blood lipid profile, not effective in migraine prophylaxis and not suitable for the secondary prophylaxis of myocardial infarction. So now when we come on the actions, they act on heart and they cause negatively, they cause negative inotropy, chronotropy, dromotropy and bathnotropy. They cause they decrease the heart rate, they decrease the automaticity of the heart rate, and all cardiovascular system, they basically the blood vessels, vasoconstriction in prone individuals, it causes direct effect, and due to additional properties of alpha 1 blockade and beta 2 agonism, they causes vasodilatation. It also has antihypertensive actions because it decreases cardiac output, decreases total peripheral resistance on long-term uses, and also decreases renin release. Now, beta blockers with vasodilator property are beta 2 agonism are celiprolol, cartilalol, bopindolol, bitazolol, vivantolol, carbidiol. So they are actually also used in any behavior changes, any forgetfulness actions on CNS. They also act as anti-anxiety. They increase dreaming. The non-selective ones. On beta blockade property, metabolic uses, what actions are shown are hypoglycemia. They inhibit the muscle glycogenolysis. Hypoglycemic unawareness is also seen due to beta blockade effect. Then the lipid levels, especially it alters HDL-LDL ratio. Then it also causes increase in triglyceride levels. What happens? Its action on eye, it causes decreased secretion of aqueous. Then in turn it causes decreased intraocular tension, but has no effect on pupil size or accommodation. So what happens on bronchus? Bronchus it causes increase in airway resistance. Skeletal muscle, it causes decreased exercise capacity due to decreasing blood flow and inhibiting glycogenolysis and lipolysis. What happens? Further, it also prevents platelet aggregation and promotes fibrolysis. And through antagonizing the catecholamine induced tremor, it also causes tremor, and it also causes inhibition of mast cell degranulation. Now what happens? They are mainly metabolized in liver and kidney. It is excreted. Now what happens? What are the adverse effects on CVS cardiovascular system? It causes precipitation of CHF. Then it also causes exacerbation of angina, bradycardia, then increased airway resistance. So it is contraindicated in bronchial asthma patients because it will cause worsening of bronchial asthma symptoms. Now what happens? What are the adverse reactions? Adverse reactions are, there are impairment of carbohydrate tolerance, alteration of lipid profile, rebound hypertension on withdrawal when used as antihypertensive. There are cold hands and feet, worsening of peripheral vascular disease. Then there is tiredness, there are nightmares, the decreased exercise capacity when we saw in muscle. Then there are many drug interactions as well. They interact and decrease the level of digoxin, NSAIDs and enzyme inducers such as cimetidine and hydralazine. It also causes drug interaction. Then what happens? Where are the therapeutic uses of beta blockers? The therapeutic uses of beta blockers are divided into cardiovascular and non-cardiovascular uses. So in cardiovascular uses, we use it in angina, hypertension, myocardial infarction, in arrhythmia, in congestive cardiac failure, in cardiomyopathy and in dissecting aneurysm of aorta. So now let's come to non-cardiovascular uses. They are anxiety, migraine prophylaxis, essential tremor, glaucoma, thyrotoxicosis, pheochromocytoma, portal hypertension and antipsychotic induced akathisia. So these were the therapeutic uses of beta adrenergic blockers. So in hypertension, we basically use cardioselective beta blockers. What is the rationale behind it? It decreases heart rate, cardiac output, myocardial contractility. It also decreases renin release and decrease central sympathetic outflow because beta 1 receptor is present at all these places. So we use in angina as a treatment. It is used in classical angina. Metoprolol, atenolol and bisoprolol and prophylactic also these beta blockers are used, but it is contraindicated in variant or prince metal angina. So what is the rationale behind use in angina? It causes decrease in heart rate, it causes decrease in contractility of heart, cardiac muscles. Also it causes in turn decrease in myocardial oxygen demand and it causes anti-anginal action. So what is the rationale behind beta blockers usage in MI? So it is used both as a treatment and prophylactically. So as a treatment it has an anti-anginal action, it reduces the infarct size and it also prevents arrhythmia. And as prophylaxis it is used to prevent reinfarction, to prevent arrhythmia. The beta blockers which are mainly used are metoprolol, esmolol and timolol. So the rationale behind usage in arrhythmias is it causes decrease in AV or AV node conduction, which in turn inhibits impulses from atria to ventricular and controls the ventricular rate, and it is mainly effective in arrhythmias which is precipitate by catecholamines. So esmolol, propranolol and acebutolol, sotalol are used. Now what happens in arrhythmia? In arrhythmia it controls the ventricular rate in atrial flutter and fibrillation. It also suppresses the extrasystole tachycardia, especially mediated adrenergically. Why it is used in congestive heart failure? It is only used in compensated congestive heart failure, where it antagonizes the sympathetic overactivity on myocardium, which in turn causes myocyte apoptosis. In turn, it decreases cardiac remodeling and decreases the progression of congestive heart failure. The drugs which are used are metoprolol, bisoprolol and carvedilol. So how and why? What is the rationale behind using in dissected aortic aneurysm? It causes decrease in cardiac contractility and aortic pulsation. Then the rationale behind non-cardiac uses are: in pheochromocytoma, it is used as an after an alpha blocker to control tachycardia, arrhythmia. It suppresses also cardiomyopathy due to excessive catecholamines. In thyrotoxicosis, it controls the sympathetic symptoms. It also inhibits the peripheral conversion of T4 to T3. It is used perioperatively. In migraine prophylaxis also it is used, especially propranolol, nadolol and metoprolol. Now in portal hypertension, it decreases the portal vein pressure in patients with cirrhosis. It also decreases variceal bleeding, and the drug of choice is propranolol. In glaucoma, the rationale behind it decreases the aqueous humor secretion, which is achieved by attenuating neuronal calcium and sodium influx to protect the retinal neurons, and in turn causes inhibition of ganglion cell death. The drugs which are used in glaucoma are timolol, carteolol, betoxolol, levobetoxolol, levobunolol and metiprenolol. Now in CNS, the rationale behind it is used as an anti-anxiety, essential tremor, alcohol withdrawal. So the third generation agents have mostly intrinsic sympathetic activity. Now where the beta blockers are contraindicated, it is divided into two: absolute and relative. In absolute conditions, it is contraindicated in cardiogenic shock, severe depression, severe bronchospasm, severe bradycardia, pre-existing high-grade heart block, overt untreated heart failure in any patients with active Raynaud's phenomenon. Then it is contraindicated in relative conditions, such as I discussed earlier. It is contraindicated in asthmatics patient, especially in mild asthma, in Prinzmetal angina, and it should not be used with verapamil or digoxin, and patients who are requiring insulin for their diabetes treatment. Thank you. So let's discuss about, again let's revise about what were the cardioselective and what were the what drugs were more of intrinsic sympathomimetic action, where in first generation were pindolol and penbutolol. In second generation were acebutolol. In third generation was labetalol and carteolol, and even celiprolol.